What's up, everybody? Hang on. For some reason, my saying it's live. What's going on? Is live now. Technology sometimes drives me nuts. All right, I see we're live on Twitter. Are we live on Facebook? Yep, we are. Okay, I'm not sure why it's not showing up on my phone. Uh, okay, it is now. All right, we are live. All right. What's up, everybody? Happy Hump Day. Happy, thank you guys. The village always comes through, man. You guys always come through. All right. Aloha, George White. Happy birthday to George White, folks. Everybody wish George a happy birthday while we wait for Charlie. Is going to be on. He said he's going to come on about 7. He's working late. Mahalo, Eric Bilsich in the house. What's up, buddy? Anyway, Charlie will be on at 7. We got Dr. Dworkin on. And I know the last time he was on, the connection was horrible. So we did a test run at 5 o'clock today. It worked. It was fine, and we're just keeping our fingers crossed that his connection up there. They have DSL. They don't have like we all have cable or fiber optics or whatever. He has DSL, so the Wi-Fi isn't as clean, but it worked fine at 5. I'm praying that it'll work fine today, tonight, because he has a lot to say. We had a little chat, which is the first time we've ever had a discussion with the guest before the show. So fasten your seatbelts, folks. Fasten your seatbelts. And it might be a good time to hit the share button. Hit the share button so we can get this to go viral. Lots to talk about. Numbers. Again, 607 daily cases in the last week. I don't know what administration is looking at. Maybe they're looking at different numbers. I'm not sure. Positivity rates off the chart. Kauai 17.9%, I believe. Watched the governor this morning, and he was like, "Yeah, we're trying to figure out why. Why is because 17.9% of the people that are taking PCR tests are positive. What's there to figure out?" He did acknowledge that it means that we have a lot of virus in the community, but if you was to look at their actions, you would think that COVID is gone. So anyway, May the 4th be with you. I'm over that Star Wars stuff. Oh man, I should have played the Star Wars Yoda or Baby Yoda opening. Son of a gun. I didn't even think because I'm really not. I mean, I saw the first Star Wars movie. That's the only one I saw. It was good, but that's just not one of my favorite um, franchises, I guess, in movies. But anyway, so yeah, we got the numbers. We got the and how about the test kits? 750,000 test kits going to be destroyed. $22 million worth of ARPA money that could have been used, and they're going to pay someone $63,000 to dispose of it. Anyway, we'll have that discussion as well with Dr. Dworkin. I you don't even know. It's gross negligence, people. It's gross negligence. And remember, it happened before last year as well. I believe it was 8 million or so. Same thing, but it's gross negligence, people, because and I don't want to say too much now. I want Dr. Dworkin because I really want to get his. I want him to chime in, and I'm concerned about the number of unreported positive. It's 5 to 7 times the amount. That's a conservative estimate. So for those of you that are wondering, if you times the 600, let's just round it off because that's easier, and you times that by 7 times 600 would be 4,200 daily cases, which is pretty much what I believe it is because of the home tests. And the amount of people that are going to work or going to school or going into the public with symptoms of a cold because they think they have a cold, are helping to spread this virus. And I'm not even going to get into the debate about the danger of this virus. I'm tired of people saying, nobody's dying, hospitalizations are down. Well, let me just tell you this: Queens Punch Bowl, the main Queens hospital, is on divert right now. So you will not be able to go to Queens Hospital on Punch Bowl. They're diverting all their patients elsewhere. Well, is it all because of COVID? No, but the hospitals are full, 95%. I think Queens West is at 85 or 90%. Um, they, I don't understand why our decision makers, policymakers, decision makers aren't seeing this. This is a concern. This is a concern, and it should be a concern. Granted, you vaccinated, boosted, you practice safe measures, you're relatively safe. But there's a lot of vulnerable people in our community, immunocompromised, our elderly, the kupuna, and everyone seems to forget. Not everyone, of course, the village doesn't, but all of our leaders um, are seem to just they're okay with just let it rip through the community. And 10 people died in the last week. Now people say, well, we're compared to the mainland. I don't care about the mainland. I mean, I do, but as far as our decisions and policies, we should be focused on 10 people to die in a week from a virus. That should cause some alarm. Yeah, well, we're not seeing the same amount of hospitalizations and death that we did in Delta in the early stages of Omicron. That doesn't mean we should be okay with it. 10 deaths, that's 10 families. Um, I'm not going to go into the impact. I mean, many of us here tonight have been personally impacted by COVID and the loss of loved ones. I've had too many. And four of the folks who died of COVID and were reported this week died at home. Yeah, I mean, it's this virus is not a good virus. So, anyway, we'll talk about that tonight. But hey, Green is wearing his doctor shirt daily, taking selfies with a big phony smile, hang out with his sign. Yeah, well, listen, guys, I'm only going to say this right now. I know a lot of people say remember in November. That's kind of the thing, the buzzword. Remember in November. Well, no, not November. The primary election is in August. And that's when Hawaii will pick their Democratic candidate and their Republican candidate and their independent, whatever. All of the parties will have one finalist in August, not November. November is too late. So everybody got to register to vote. Everybody got to get out to vote. Remember in August, not November. And the scuttlebutt is out, right? The rumor mill is out. What's Kai gonna do? Well, I just got off the phone with Kai about an hour ago, and Saturday morning at 10 o'clock, he will be making a he will be having a press conference. I think you all know what it's gonna be, but I'm not gonna blow it. I know. I think many of us will be extremely happy. Saturday morning, 10 o'clock, I will be streaming his press conference live on my Facebook page. I think you can figure it out. But his race is in August. Oh, I'm sorry. Did I just let the cat out of the bag? Sorry. The primary is in August, not November. So the governor's race is, guys, I guess what I'm trying to say is go register and make sure you vote. It's the only way we will be able to make change. All right, Saturday morning, 10 o'clock. I will be sharing the link as soon as he sends it to me. So y'all can watch it on your own, or you can watch it on I will be, like I said, I will be streaming it live on my Facebook page, on YouTube, on Twitter, and on LinkedIn. All right. So that's kind of good news. I'm voting for Kai for governor, Mel for council. Uh, you know, Thank you. Rena, thank you so much. Yeah, the word was out already about Kai running for governor. I know, but it's not official. It will be official on Saturday at 10 o'clock. But you got to vote, guys. Okay. A lot of people are saying that that Josh Green has a head start. Well, he did have a head start, but that doesn't mean anything in politics because the person with the most votes will win. And again, it's the August election that is critical. Okay. So anyway, um, and then one more thing is on Saturday. I'll share this again, but on Saturday morning, um, COVID is a big issue, but not the only issue. Bingo, absolutely right, Scotty. There are so many issues that's going to be facing this next administration at the state level and on the counties as well. And that's why I decided to run because I just not feeling the the connection on Kauai anyway. So I'm hoping that I can bring my experience back to the council and hopefully bring the transparency back, bring the accountability, which is so vital in politics and in government. People got to be held accountable. People got to be held accountable. And, the test kit deal is a great example. You did that in a private sector, you'd be gone, gone. If you did that in the military, fraud, waste, and abuse complaints would be filed, possibly court-martialed. And here, state government, no problem. Sorry is okay. No, it's not okay. Now we're talking about $22 million. Now when you're talking about having to dispose of tests that we needed last year. We needed those tests. I know Kauai did. I know the Big Island did. I know the neighbor islands did. So, again, I cannot, I'm at a loss, total loss. But anyway, Saturday, 7 o'clock, Vidina Stadium. For those of you on Kauai, Special Olympics is hosting their annual Troy Barboza Law Enforcement Torch Run. You can run if you want. I'm going to be walking, and I'm looking for some walking partners. So 7 o'clock, Vidina Stadium. It's just around the track, and it kicks off the opening of the Special Olympic Games for our wonderful Special Olympic athletes. So if you can, it's $30. You get a free T-shirt. You get to walk with me, and we'll talk story, and we'll have a blast. So please, 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 if you can, Saturday morning, 7 o'clock, Vidina Stadium. Troy Barboza Law Enforcement Torch Run. As you know, Troy Barboza was a police officer on Oahu, murdered in his living room, shot with a shotgun. And they named the run after Troy. So Saturday morning, and look who's here. And look who's here. Okay. Doc, are you there?
I see you guys. How's
Charles,
my audio tonight?
Well, the fingers are still crossed. I explained to the village that we did a test run and it worked fine. I didn't want to end the connection for fear that it would be. So anyway, you're good. I can hear you good. Charlie, I can't hear you, Charles.
What about now?
Boom, shaka laka laka boom. Look at Patsy. Patsy's on. She says, hi, Mel. My dad, right after that. Hi, Mel. Good evening. Aloha, everyone. Hi, Charlie, he says.
Hey, how you doing? How you doing, Doc? How's everything going?
Doing pretty well here. How are you guys?
Doing fine,
Oh,
thank you.
I'm even more excited because you're coming in crystal clear, Doc.
Yep.
Woo! Prayer works. Anyway,
Hope
lots to talk about, Doc. If for those of you that don't know, it's been a while since we had Dr. Dworkin on. He's been pounding the pavement up there on the Big Island. He'll share a little bit about what he's going through and been going through for the last couple months. But he's Dr. Jonathan Dworkin. He's an infectious disease expert specialist. So he's not a online
I'm not a
phony guru. Twitter doctor. The Google University graduate. No, this is the real deal. And Doc, anytime we can get you on, we appreciate. So anyway, let's start off, Doc, with the numbers. I think it was 4,700 plus since last week. New cases since last week Wednesday. 10 deaths. Positivity rates rising. Kauai 17.9% positivity rate in the last week. Hospitalization slowly rising, not to the proportion that it was during Delta and the onset of Omicron. But what are your thoughts concerning, and you're seeing it from ground zero? What are your thoughts, sir?
Well, before
Yeah,
he
I mean,
answers,
Oh, oh, oh,
can I ask
sure.
him a question to add
Yes,
on
yeah,
to that?
absolutely.
Doc, I just need to find out, why is there not an urgency this time around where the numbers seem to be mimicking the numbers from previous, and we went into a heavy duty fire drill at that time, and this time it seems like we're taking a leisurely walk down to Hilo Bay. So maybe give me your insights on that as well. Thank you.
yeah. I mean, it definitely it's gotten less urgent each time, doesn't it? In terms of the policy response. I mean, we're definitely in another wave right now. It doesn't feel like it because we're not getting daily reports like we were before. Just the fact that they switched from daily reporting to weekly reporting, I think, has shifted the psychology of this a little bit, which I think was probably intentional on their part. Um, but there's just no doubt we're in another wave, and all of us are seeing it every day now. It seems like everybody around me is exposed or infected. We've definitely had a lot more cases. At least here on the Big Island, there was certainly a lull in March where things seemed a lot more normal in the sense that there just weren't a lot of cases and things were opening up. Now I'm noticing it, people are being a lot more careful. We're seeing a ton of COVID in the community here. And the vast majority of it is outpatient. And I'm sure other guests have made this point, but one of the things you have to realize is that those official DOH numbers, they're reporting, PCR confirmed tests. That doesn't take into account people testing themselves at home, which is increasingly common. And with the rising test positivity, what that also means is that there's a lot more cases out there. So the real number is certainly in the thousands per day of cases. I suspect thousands plural, and that's where we're at right now. It has not translated on my end into a huge hospitalization wave, at least not yet. And I'll give you my ground level view because it may be a little bit different than the perspective you get from other people. But during early pre-vaccine waves, we had a very tight correlation between cases and hospitalizations. So just to give an example, I was at Queen's Punch Bowl in Honolulu when the very first wave hit. And that now seems like a tiny wave, right? I think it peaked at about 30 or 35 cases a day. I'm talking March, early April 2020. That little tiny wave that now seems like a speed bump translated into 20 to 25 admissions at Queen's Hospital and about half the ICU beds full in our main medical ICU. And then it melted away because that was the first lockdown and the 14-day post-arrival quarantine, right? But that was what 30 to 35 counted cases a day did in 2020. So now we're at like 600 cases a day, probably thousands plural. And you look at the big board on the hospital, and what you see is about 20 to 25 patients with COVID admitted to Queen's Punch Bowl Hospital. We have one right now at Queen's North Hawaii Hospital, where I'm rounding. Now that doesn't mean it's going to stay low. What happened with the Omicron wave was the cases were really rising very quickly, and then the hospitalizations did rise, and we peaked at a high number of hospitalizations during the BA1, the early Omicron wave, and it was almost as high as the Delta wave. I think the Delta wave was our highest in terms of number of hospitalized patients, but at Queen's North wave we had about half our beds full of COVID, and during Omicron it was about a third. And I'm really hoping that this time it's less than that. But I have no doubt that we're in a wave, and I have no doubt that hospitalizations are going to go up. It correlates. It's just not correlating as tightly as it was at the beginning.
I know that Queen's Punch Bowl is on divert right now, and it's not because of COVID. It's because collectively the beds are filled. They're, I just saw a friend of mine just sent me the divert notice from Queens Punch Bowl, which is the major hospital. It's a
Yeah.
huge, and that should send a little uh, caution to our policymakers and
Right.
let them know that
The
we're
hospitals are full. And another related point is the types of admissions we're seeing. So, earlier in the pandemic, everybody coming into the hospital had bilateral pneumonia. So, I mean, it wasn't subtle. It was like you had COVID, you tested positive, and, we did an x-ray on you, and it was like, bam, you whited out lungs on both sides. And these people were in hypoxic respiratory failure. They were dying of their lungs filling up with pneumonia. And we were trying to keep them alive. That's broken down a bit, and it's been a little harder to tease out in recent data, what should count and what shouldn't count for a hospitalization. So I'll give you guys a couple of examples because I personally have been wrestling with this. We still do get kind of admission. We get a person who comes in with bilateral pneumonia with COVID, the classic. I think of it now as the COVID admission, and these tend to be middle-aged or elderly people who are not in very good physical shape, and almost all of them are unvaccinated. Right? And they come in with the classic pneumonia. This is like the 2020 COVID that we saw. But we're also seeing different types of admissions. Now, we're seeing people who were vaccinated, but maybe are just very medically frail and get COVID. And they come in and they don't necessarily have bad pneumonia, but the viral illness just sort of pushes them over the edge a little bit. Maybe they fall at home. Or I've had one, two that have come in with like what we call non-ST elevation MIs, which are basically small heart attacks, which I think are probably related to getting infected, but they're not the pneumonia type admissions that I was seeing at the very beginning. And how to count these and how to attribute them is a little bit tricky. And then there are people who are coming in that have absolutely no COVID symptoms, or very minimal COVID symptoms, and they're admitted for a completely different reason. And then we just find that they happen to have COVID, and it doesn't seem related at all. And it's because the disease is just so common in the community, right? So it's become a little bit messy to figure out, well, how bad is this, and how much is it driving things? And for example, one of the things I've noticed is that like the British, who have one of the best data report comes out every week, they actually define hospitalizations in different ways. So they have one category that's just anybody who's in a hospital who has COVID. And then they have another category for, you're in the hospital with COVID and you're on oxygen, and we think that the COVID is causing you to have lung injury, right? And that's the category that I tend to look at a little bit more closely when trying to figure out, how bad it is, right?
Okay, so I guess my follow up question to you will be, Doc. For the lay people out there, I mean, I myself, I'm not a physician, but I've kind of been around a few blocks. I mean, a few times around the block, like many others out there, heart condition, open heart surgeries, that type of thing. People with high levels of diabetes and whatnot. Because this this virus at this point is acting the way it's acting, we'll probably won't have a definitive aha gotcha moment, right? I mean, it
No,
seems like we're kind of like walking on eggshells, but I'm sure everybody wants to lead a normal life, and but we're always promoting safety first because I don't see that many flus coming around. I just went to the doctor the other day, and but the thing is, this behavior of this virus, the way it is right now, is that what is contributing because it doesn't have no outward explosive signs like we've seen before? Is that the reason why everybody taking it with a grain of salt is just it's done already? Is that the reason
well,
why
yeah,
they're acting that way?
it's really it's I guess what I'm getting at here, and this kind of fits with what I was just saying, is the disease has shifted on us. And um, in 2020 we had a disease that was more contagious than influenza. I would say, slightly to moderately more contagious than influenza, and I think about 10 times as deadly as influenza. And now we have a disease that is, as contagious as measles, way more contagious than influenza, possibly the most contagious respiratory virus we know of. And yet the fatality rate now is a lot closer to influenza. In many demographics, it may even be lower than influenza. So this is a fundamentally different problem, and it's not that it's not a threat. It's a threat. It's definitely a threat. But the dynamics of it have shifted, and they've shifted in a way that, I don't think was entirely predictable. I mean, I expected over time the fatality rate to change as we got vaccines and as we got medicines. But I don't think anybody expected it to become this contagious. And that's sort of a threat itself, right? Because you see how fast these waves gather steam. And with the virus that's that contagious, we may be in a situation for quite some time where we're continuing to have waves. And maybe the vast majority of people do pretty well during those waves. They don't necessarily end up in the hospital. But some people are going to end up in the hospital. And some people are going to end up with things like long COVID. So we can't just ignore it. And I think this is a kind of new normal that we're adjusting to, myself included. To get at your situation, Charlie, I don't know how much of the health information you disclosed there was you or friends or family. I have a lot of family members, friends, patients that are in this situation now where they maybe have 2 or 3 risk factors, and they really want to do normal things. They want to travel, they want to see family, they want to have kids over. And one thing that's coming up right now for me as a clinician is what's safe to do and what's the safe way to do it. And I developed a sort of formula that I've shared with people in my life, and maybe it'll be helpful to people out there. I hope so. But the way I think of it is that I try to have a kind of layered defense for people. And layer number 1 of the defense is mRNA vaccination, right? Until something better comes along. And there's a lot in the pipeline that may either supplement or augment or even replace mRNA vaccination. But these vaccines are still highly effective at preventing the worst outcomes. And I'm willing to go through that data. I will in a minute. But the first step is just be with your vaccination. So that's either 3 shots or 4 shots, depending on your situation. If you're up to date with your vaccination, the likelihood that you're going to have a bad outcome, that you're going to end up in the hospital, is reduced by, we think, about 80 to 90%, just by doing that one thing, right? There's other things you can do, though. And the other really new thing, and the thing that's been taking up most of my time as an ID doc on the Big Island, is early access to antiviral therapy. And we have now a couple different options for antiviral therapy that have good clinical trial data behind them, that have emergency use authorization, and that should be available. But they only work if you give them early. You got to give them early in the course of the illness. For packages, the oral antiviral therapy, that's got to be given within 5 days. And the monoclonal antibody is 7 days. So what I've been telling everybody is, okay, high risk, first of all, make sure your vaccination is up to date. Second of all, make sure you know how to access antiviral therapy in your community, whether it's Paxlovid or monoclonal antibodies. And if those things are not available in the community, they really should be. The healthcare system needs to be responsive and make these things available. It's been one of the big things I've been spending time doing. And when people call us here in North Hawaii, we try to get them treated within hours. We're at the point where I want to have people on oral antiviral therapy, people who are high risk. I want them on oral antiviral therapy within hours of being diagnosed, not days, hours. And if you do that, the evidence that we have suggests that that's another 80 to 90% reduction in your chance of having a bad outcome. And then for the highest risk people, we actually have a third layer of defense, which is another monoclonal antibody called Evusheld, which is for pre-exposure prophylaxis. So these are people who are particularly immune suppressed, cancer patients, people on chemotherapy, things like that. And fortunately, I'm in a small town. There's one oncologist here. I walked into the oncologist's office and I just said, listen, I want everybody in your clinic to get this monoclonal antibody, like as quickly as we can do it, who you think is immune suppressed, which is almost everybody he's seeing. And we've been doing that for a couple of months now. So we've essentially pre-exposure prophylaxed the highest risk people in our community. And then I still tell those people, if you get sick, I want to hear from you within hours so that I can get you to treatment early. So we have 3 layers of defense for these highly vulnerable people. And I think that's one of the major reasons why we're seeing this disconnect now between cases and hospitalizations. It's exactly what I would want to see if the medical system is functioning. And I think the problem that we're having is it's spotty. It depends what town you're in. It depends what hospital you're in. It depends who you have access to. It depends on the attitudes of the doctors and the administrators at whatever healthcare system you're a part of. And I'm still encountering this very pre-COVID attitude of, well, we conserve resources and we've got to hoard and we've got to make sure that everything is done perfect and that our paperwork looks good. And my big push here in Waimea has been, no, forget that. We want people to be able to get treated quickly. That's how we get back to a normal way of doing things and don't have our hospital fill up. So that's what I've been pushing for. And I don't know how it's going at every system in the state. I know I've been nudging Honolulu from afar a little bit to be a little bit more liberal with their prescribing of antiviral therapy. But that's what I would say. I would say have a plan to do that. And then if you're going to be in a really high risk situation that you know is high risk, like the airport, definitely wear an N95 mask, because that's a super spreader event that's essentially become continuous since the court ruling overturning masks in public transit arenas.
So what you're saying, Doc, is right now, I think for most healthcare locations, if I'm at home and I test positive on a home test kit, I call my doctor. Doctor says, hey, go get a PCR test. And that may take 2 or 3 days to get your results back. What you're saying is that, hey, you test positive, home test, you got symptoms, you're starting your treatment now. We don't need a PCR test. Is that what you're saying?
That's how I do it. Yeah, and it's more controversial than I think it should be. There are still systems that are requiring people to get confirmatory PCR tests or other lab tests to get oral antiviral therapy. But my take on it is, if you have symptoms of COVID and you have a positive rapid test, you have COVID. What the hell else is it? It's not dengue, it's COVID. So why do I need to expose a lab tech and waste 2 days getting a PCR test on you? I mean, it's nice to have the numbers. I understand it's nice to have a central tabulation of all the data. But what's more nice? What's more nice is not having people get sick and come to the hospital with pneumonia. So that's where I think the priority should be and the focus should be. I do worry about inappropriate prescribing a little bit, because these are emergency use medicines. So we do have criteria. It's not like a regular prescription. You don't just order it like you're ordering Zyrtec or something like that. It's the way we designed it here is it's a one-page order form that the physician has to fill out. And it can be any physician, though. It doesn't have to be me. It can be a community primary care doctor. It can be an urgent care doctor, an ER doctor. And they have to attest the form that, yes, this patient has symptoms of COVID. And yes, they have some kind of test saying that they have COVID. And yes, they have risk factors, because we don't need to give oral antiviral therapy to people with no risk factors. So yeah, have some kind of risk factor, and that they don't have a contraindication. And there's unfortunately pack of it, which is the one that tells the contraindications. So the doctor has to go down that and then attest that they don't have that, and then sign their names that they're accountable. And then, if they do that, we give them the medicine. We don't argue, make them jump through extra hoops. And I want that to be available for everybody in Hawaii. I'm not sure that every system is doing that yet. I think there's still too much hoop jumping that's going on in much of the state. Monoclonal antibodies, in a weird way, are easier because there's fewer reasons not to give them. There's fewer drug-to-drug interactions. There's fewer contraindications, medical contraindications. And you have 7 days instead of 5 days. So even though it's an infusion, it's actually more people are eligible for it. And I think that's more available in some places, often through the emergency room, if there's no other way to do it. We have set up infusion clinics. In some places, we had an infusion clinic here in North Hawaii. We ended up merging it into the emergency room because it was just easier. So most places will give monoclonal antibodies through the emergency room. So worst case scenario, if you're high risk and you're being blocked, you can go to an emergency room, and most hospitals have it available in the emergency room now. So that's another option for people. The mistake is sitting at home and waiting until day 8, day 9, day 10, and then you're still symptomatic, and then you want to be treated because you've missed the opportunity to kill the virus. The virus has to be killed fast if you're going to avoid the sort of bad outcomes of COVID. So I tell my patients, it's got to be fast. The whole system has to be fast. Speed is the virtue. Perfection is not the virtue. It's being able to move and get people into treatment. And that's what we're trying to do.
Hey, Doc, some people are asking, I guess, similar questions about waning immunity, boosters, mixing of vaccinations,
Yeah,
immune compromise, whether or not there are layers that can be applied when you're immune compromised. And I think,
yeah,
everyone is, I hate to say it, but, everyone's different how their body reacts, right? I just had one of my workers on one of the outer islands call me and says, "Hey, I got COVID," but he was almost at a asymptomatic point. It's just that he had a little scratchy throat.
yeah,
So he
yeah.
did a home test, and then he went in and took a
Right.
PCR as a follow up, and it
Yeah,
confirmed. And then his entire family didn't have it. But then 2 days later, they got it, but they got it worse. I mean,
yeah.
the high fever, everything. It was body aches to the max, and so, can you talk a little bit about, how what you're seeing and how this thing is hitting individuals, and what do we do
It,
about, mixing boosters and all of that?
it's always been like that. It's just that there are more people with more mild presentations still because we have a better vaccinated population, and we also have a large number of people who've been naturally infected. Probably at least a quarter to a third of the state. It's a little difficult to pin down. I think there was a serology study that came out about a month ago on this. So there's a lot of immunity now in the population. So there's more mild disease. But one of the weird things about COVID is that there's always been these highly variable presentations where some people really don't get sick at all. And if you're one of those people, it's understandable that you would think, oh, this is no big deal. This is no, that's Joe Rogan experience, right? Remember Joe Rogan got COVID and he got, what did he do? He took ivermectin, then he got a monoclonal antibody. Then he went on the show and told everybody it was a really mild disease after getting, the gold standard treatment. But anyways, for some people, it really is mild, and for some people, it's asymptomatic, and other people feel like they got hit by a truck. And the fact that you feel like you got hit by a truck doesn't even mean that you had disease. You can still have mild disease, meaning that you're not hypoxic, your lungs are working fine, but you feel like you got hit by a truck. So we call you mild, but it doesn't feel mild to you. Other people don't feel that sick, but then their oxygen saturation drops down to 75% and they look blue, and their family members take them into the hospital and they've got pneumonia on their x-ray, right? So the symptoms have always been all over the place for people. And that's just part of the nature of the beast. What I would say with the vaccine stuff, these vaccines have become very maligned because of our fragmented politics, but also because of the increasing number of breakthrough infections, which is a real thing. But there's remarkable consistency. This is to reassure people. I would reassure people by saying there's remarkable consistency in the efficacy of the vaccines, and you don't have to believe one source of information. You never should. You should always cross-check information, especially medical. But we have data from multiple countries, well-designed trials, and they're all remarkably consistent with the vaccines. So, there's the American data, which came through the original two, big clinical trials for Pfizer and Moderna, and then all the post-availability data that came after that, looked from healthcare systems. And in recent months, we have the CDC data where they're looking at, with their Vision Network, which is the CDC alliance with big healthcare organizations around the United States. And they report vaccine efficacy data. They look at breakthrough infections very carefully in this collection of hospitals and who's getting hospitalized and who's not and what's their vaccine status. So there's that, right? There's data from the UK Health Security Agency, which I mentioned earlier, where they publish a weekly report on all the UK hospitals, looking at who's coming in sick, what their vaccination status is, how many shots they had, how long it's been since their last shot, this information, right? And then there's Israeli data, which has been used for boosters in particular, but they've got a couple different types of trials that they do in Israel. They've got a big healthcare system called Khalid, where they look at elderly people that are in this gigantic healthcare system, all in one electronic medical record. And they look at vaccine efficacy and they look at boosters very carefully in that population. And then they've got another big data set where they look at healthcare workers. These are kind of young middle-aged people who are working. And the nice thing about that data set is these people get tested all the time, regardless of whether or not they're having symptoms. So they can crank out vaccine efficacy numbers in like the working age population, and they can look at asymptomatic and very mild breakthrough infection. So I'm saying this because what's interesting to me about it is all of this data kind of rhymes. So you look at the data from Israel, you look at it from the UK, you look at it from the US. There's Japanese data that just got published a week ago that I was looking at. And what you see is kind of the same story, which is that, if you get 2 shots, your protection against the original virus was very, very good. It was in the 90-something% range. The protection against the newer variants with the original shots is not as good. Your protection against any breakthrough infection is probably closer to about 50%, but your protection against being hospitalized is still closer to 80 to 90%. And then it wanes with time. So what happens is, I'll just give one example. From the UK data, they looked at people over age 65, and they looked at people who were 6 months out from their second shot. And this was during the Omicron wave. So we're talking older people, 2 shots, and 6 months out from their second shot. And the vaccine efficacy was 73% for avoiding pneumonia, bad hospitalization. If they got a booster shot, it was up to 86%. And that persisted again for about 4 or 5 months, which is the longest they have data after the 3 shots. And that's actually very similar to the data we're seeing in other countries. So the vaccines work at preventing pneumonia, and they work at keeping you out of the hospital. But with Omicron and some of these new highly contagious variants, you really do need to get a 3rd shot to keep that efficacy very high. And I really think of it now as a 3-shot vaccine. And the reason why I think of it as a 3-shot vaccine, it's not just because the vaccine efficacy is higher. It's because you have more antibodies against variants with 3 shots than you do with 2 shots. It's the immune response is qualitatively better as well as being quantitatively better. And that's why, in my mind, it's going to be a standard 3-shot thing if we stick with these mRNA vaccines. And then the 4th shot is really properly thought of as a booster, because if you look at the Israeli data for the 4th shot, what you see is it gets you back to about where you were after your 3rd shot, but it doesn't do much more than that. So you're giving that to the higher risk people who may have their antibody level dropping, people who are in their 70s and have cardiovascular disease, and it's been 6 months since their 3rd shot, and you're worried that they're going to get an infection that may trigger a heart attack or something like that. They're probably not going to get pneumonia because they've already had 3 shots. But that population is a little bit more vulnerable, so you give them the 4th shot and you get them back to where they were around the time of the 3rd shot. So that's kind of the way I'm thinking of vaccines right now, is it's a 3-shot business, and you just should think of it that way. There's things coming down the pipeline that use different technology that may change the way we think about it. But that's, in my mind, that's still the first line of defense, and it's a good line of defense. If you're up to date, you're in this, anywhere from 70 to 90% protection range, depending on how you define it.
Hey, Doc, I just want to, for clarification, because there are many of us that took Johnson and Johnson. So when you say 2 shots, is the 2 shots of Pfizer or Moderna equivalent to the 1 shot of J&J? In other words, because you say 3 shots series.
Right. I know you're a Johnson and Johnson guy, partly at my urging, and I feel bad about that. So I have the Johnson and Johnson data ready for you. I still think there's a role for it. I don't recommend Johnson and Johnson anymore because, the efficacy has been consistently lower. That's strike 1. Strike 2, there was this rare but serious problem of blood clots, mostly in younger women. But that was a serious side effect. Unlike all the fake side effects people have tried to ascribe to vaccination, that was one that was actually consistently seen, right? It's not common, but it's severe. And then there may be a slightly increased risk of Guillain-Barré syndrome. That's still being argued. There is some data suggesting that Guillain-Barré syndrome is a neurologic syndrome, which is disabling, right? So those are serious side effects. They're rare, but they're not really seen with the mRNA vaccines, and that's why most American doctors aren't using Johnson & Johnson anymore. There are people who just hate mRNA vaccines, but don't necessarily hate Johnson & Johnson because it's an older technology. And for those people, it may still be appropriate. It's way better than nothing. So if you have, according to the CDC data on Johnson & Johnson, Mel, if you have 1 Johnson & Johnson shot and you got way back in the day, and you haven't done anything since then, and now we're in the Omicron wave, you are 30% protected against hospitalization, 30% with 1 Johnson & Johnson. If you got a second Johnson & Johnson, you're all the way up to close to 70%. And if you did a Johnson & Johnson plus an mRNA, you're up to 80%.
Okay, I guess that was the question. So my Johnson & Johnson, I got boosted with a Moderna. and I'm fixing
Yeah.
to get another my third shot, which would be everyone else's fourth shot, will be also
Yep.
Moderna. My
Yeah.
Johnson and Johnson and my Moderna, is that equivalent to two Modernas and a booster,
Yeah.
or two Pfizers and
I think
a
so.
okay.
So what we're doing with boosters is if you got a Johnson and Johnson, then your first booster is your second shot, right? And then your
Hmm.
second booster would be your third shot. So if your age is greater than 50 and you have any kind of medical problems or you're immune compromised, you would get 3 shots if your first one was Johnson and Johnson, whereas everybody else is getting 4. So it'd be J
Okay,
and
got it.
J, then either Pfizer and Moderna, then either Pfizer and Moderna for number 3. I would think you're about equivalently protected if you do that.
Okay.
Um,
Now,
so
one more real
that's what I'm telling you to do.
the mixing. I know Charlie mentioned this. The mixing, um, Moderna, Pfizer. For those of us out here that are planning to get their booster, their fourth booster, or even their third booster, what's your recommendation? Stick with what you've had, or switch them, or does it even matter?
I don't think it matters much. The data is that the outcomes are about equivalent when you mix them, and there may be some theoretical advantages to mixing. I've seen that argument made by some very smart people in the ID community that we think that the immune profile may be slightly different in response to a Pfizer than in a Moderna. Certainly in response to a Johnson and Johnson than in an mRNA. So there may be some theoretical advantage to what we call heterologous boosting, where you get a different booster than your primary series. And in fact, that's what I ended up doing. My first 2 were Pfizer's because I'm Queens, and Queens is apparently like a Pfizer, only kind of operation at this point. And I actually didn't have a good immune response to the Pfizer. It didn't. I had no side effects at all, which was alarming to me. I wanted some side effects to know that it was working, and I had none. I didn't even have a sore arm really. And then when they checked my antibody titer as part of the Quasar study, which is a Queen's study, they're looking at antibody levels in employees because they're tracking it in healthcare. It's our little local virology epidemiology study. My titers were junk after 2 Pfizers. I went and got a Moderna as my third, and it kicked my butt, and I was very happy about that. I was down for a day, and I haven't had my titer since. I'm waiting for them to invite me back to do it again, but I'm confident it got a good depth for that third shot. So I think you can individualize that decision, and if 2 Pfizers really kick your butt and you don't want the dose Moderna, stick with Pfizer. That's what my wife did. And if you're me and you didn't have any real reaction to the Pfizer, then switch and get a Moderna. I think you can kind of game that a little bit, and the data suggests that the outcomes are equivalent, at least at a population level.
Well, I'm going with Moderna because it didn't kick my butt, and I don't like to get my butt kicked. So I'm just gonna go with the Moderna. One last
Well,
question. You mentioned Evo Shield. I just want to get you real quick so we can close that door. Evo Shield. I know my dad was here from Seattle. He went back, but his doctor is recommending that he get Evo Shield as a preventative. I know you mentioned that earlier. What's
Yeah.
your Go ahead.
People should Google it because the New England Journal study just got published, I think, a couple of weeks ago. So there was data through the FDA authorization, but it finally went through the full peer review process and got published in New England Journal. And it was pretty good, guys. I mean, this was done, pre-Omicron. So and I think pre-vaccine as well. I'd have to go back and look at that again. I think so you have to be a little careful extrapolating from the situation a year and a half ago to now. But that said, it was very effective at keeping people out of the hospital. It was about 80% effective at keeping people out of the hospital. And not only that, the effect persisted. They followed those people for a full 6 months, and it was still 80% effective at keeping people out of the hospital 6 months later. And when they looked at their antibody levels of the monoclonal antibody, it was really high. So most monoclonal antibodies we use for treatment, and they clear out of your system within a couple of months, 2 to 3 months, we think. This one stays in your system for a full 6 months, and it's intended to be used before you're exposed. So we're giving it to high-risk people. And another wrinkle, and I didn't realize this, was they were pretty liberal about who they included in the study for Evusheld. They used it on people that were like late middle age, early elderly, so a lot of people in their 50s and 60s. and most of them had relatively common risk factors. So, the most common one was obesity. I think the second most common was high blood pressure. The third most common was like smoking, tobacco history, right? So these were fairly common conditions in the population, and they seem to benefit tremendously from it. We, as a practical matter, we've been using it on the more highly immune suppressed population. We've been using it on, oncology patients and transplant patients and people like that. I think it's fair to ask whether we should be a little bit more open-minded and offer it to more people. One issue that's come up is the efficacy against Omicron, and there was a big reduction in the test tube efficacy of the drug against the original Omicron, the BA.1 variant that was circulating in the winter, and that chilled the enthusiasm of a lot of doctors for Evusheld, because we thought, well, okay, great, it worked a year ago, but BA.1 seems to be more resistant. Is it really going to give us any significant benefit? Interestingly, it seems to work pretty well against BA.2, which is now replacing BA.1. So in a way, the virus helped us out there. And the patients that got Evusheld at our clinic, I think, are protected against the current circulating variant. I would still treat them if they got infected. If they get breakthrough infection, I'm planning on treating them. But why not have that extra layer of defense if you're in a highly vulnerable situation? To me, it just makes sense to do it.
Thanks.
Well,
Charlie?
that just goes to show you, mixing, whether it's 7-7, Jack Daniels, or any of those drinks, it'll knock you out.
I'm big into the mixed drinks for COVID, Uncle. And what I tell the Evusheld people is, we get them up to date with their vaccines first. So if they haven't been boosted,
Yeah.
I don't want the Evusheld to replace the vaccine. So I want them to have the 3 layers, right? So first thing I do is I get them up to date with their boosters. And I said, don't even think about Evusheld until you've had your 4th shot. You're highly immune compromised. We're going to give you your 4th shot. After you get your 4th shot, then we do the Evusheld. After we do the Evusheld, you got my phone number. If you get infected, I want to hear from you within 24 hours. Then we give you the antiviral therapy, right? So this allows people to feel confident that they're being looked out for, right? And I want that for everybody in Hawaii, right? Because, God knows we're not controlling transmission anymore. We've given up on that completely, as far as I can tell. So we better have our act together with these therapeutics, and it requires constant adjustment because stuff is going to change. We've gone through 3 different monoclonal antibodies. Mel and I were talking about this before. The first monoclonal antibody I used during the Delta wave didn't work against Omicron, so we had to switch. Then the second monoclonal antibody we had against Omicron didn't work against BA.2, so we had to switch again. We're now on our 3rd monoclonal antibody at the hospital. And probably at some point we're going to have to throw that one out and switch to another one. So I hope every hospital on the island has somebody who's keeping track of this stuff and updating it, and if not, partnering with a facility that does, so that these things are easy to get for people. That's what we want.
How, or have you heard of any way that the state is actually tracking those travelers coming into the state who are sick, no matter whether it's serious or just a smidget of this virus, because it's just adding to the mix, right? I think everybody wants it to be completely gone out of our system, but
Yeah.
since the relaxing the program at our borders, there is no real way of definitively understanding what the numbers are like. I mean, we're only catching numbers when someone shows up at a hospital, or when
Yeah.
somebody goes in and it's a reported issue. Other than that, like you said, home test kits. I mean, unless there's a way of, really defining how many test kits have been sold and what we find in a rubbish can, then that will tell you if something happened or not, right? So, what's your take on that, Doc? Do you think that as a state we're doing an okay job or not good enough?
I don't think we're controlling transmission at all, and we're certainly not controlling the border. And you guys know this has been a big theme going back to the book I wrote about this, Plague Doctors. It was one of the hot topics in the book, was what to do with border control. And what we saw was the places that had stricter border control, like Hawaii, they had less cases in general. And then they also had fewer viral variants enter. So Kauai was the best. And then the second best was the Big Island. The Big Island had a kind of modified safe travels where there was pre-travel testing and then there was a post-arrival rapid antigen test, which did not find a whole lot of disease, by the way. But interestingly, our numbers were low and we did not have as many variants circulating here in late 2020 and early 2021. Oahu and Maui did their safe travels and almost immediately had all the variants that were circulating on the mainland circulating on their islands. So we know just from that alone that there was no delay in viral variants entering the island. And now what we have is really no border control whatsoever. And we have the viral variant report that comes out every couple of weeks. And if you look at the viral variant report, you see that Hawaii tracked almost precisely. So we had BA1, which was the original Omicron in the winter. Now we have BA2, which has replaced Omicron everywhere. And I think in the most recent viral variant report, we had 20 cases of BA2.12.1, which is the latest Godzilla subvariant, which is now taking over the Northeast, and it's already here circulating in the state. So we're getting everything that everybody else gets.
Real quick, because I do wanna talk about testing, and I do want to talk about the expired testing, but Scotty's asking about valciclovir and Valtrex. Do they help in fighting COVID?
Valciclovir is a herpes medicine, and it's very good at fighting herpes. I'm not aware. I also mean VZV, not just herpes, which causes venereal disease, but also the herpes simplex virus that causes cold sores, which is not necessarily venereal, and also varicella zoster virus, chickenpox. It's a medicine that's used for those herpes family viruses. So I'm not aware of any data on that for COVID. I might have missed a study or two looking at it. Someone earlier asked, and
Valtrex is the same thing.
Valtrex is yeah. I think it's just a different. Okay. It's a different brand, like a brand name or something. Someone earlier asked about Paxlovid and do we need to extend the duration? And this is the oral antiviral therapy that we're using for COVID. And there are these reports of people getting better on Paxlovid, and then they feel better, and then they leave isolation on day 5, and then day 6, day 7, sometimes as late as day 10 even, they start getting symptoms, and then they test positive. And it's very alarming and it's very concerning. And it's not a lot of people. It's just a few percent of the people that get valciclovir, a few percent of the people that get Paxlovid. But there are people who seem to be getting what we call phenomenon on the Paxlovid, where it suppresses the virus and feel better, but then when they go off of it, they get worse. And I wouldn't be surprised if there's some changes in the dosing recommendations. It may end up being that it's better to give people 7 days or even 10 days rather than 5 days. Right now, we're authorized to give 5 days. And if somebody has that experience, they should know that they're infectious, and probably the doctor should give them another 5-day course, should extend the duration. Fortunately, I haven't had it happen to me yet, but I saw in the comments someone was asking about it, and it's definitely something to be aware of if you go on Paxlovid. If you go on Paxlovid, you feel better, and then you feel worse again, you may be experiencing this rebound phenomenon. Call your doc, put a mask on, don't go out, test yourself, and see if you need an additional few days of therapy, because it's a new medicine, so we're still learning some stuff with it. But the hospitalization avoidance is really good with it, at least in the clinical study. It was about 80%. So I'm still going ahead and using it. And the convenience factor is huge too. I mean, you can just literally drive up to a pharmacy and pick it up, which we've never been able to treat COVID that way before. So I think that alone has made it much more accessible for people.
I know our former council chair from Maui, Gladys Baisa, is watching, and she asked about the EvuShield. I'm assuming she can contact her doctor. She's 82, she said. She's immunocompromised, and she's boosted. Her doctor would do it. Okay.
Yeah,
that would qualify, right? 82, immunocompromised.
It depends.
And I'm
It
not.
depends. It depends on what we mean by immune compromised. And in Queens, we have a list of conditions that count as immune compromised. And one of the things that was interesting to me was when I saw the study come out, the list that they were using for the study that got published in the New England Journal was a much bigger list than the one that we're using at Queens. So one of the questions that I think is going to come up is, should we be making this more easy to access for people? But yes, if you're immune compromised, it's often available through the infusion center at the hospital. So hospitals often have infusion centers. This is where they give like chemotherapy for patients getting chemotherapy, or sometimes antibiotic infusions for patients that are on long courses of antibiotics. So the typical process with Evusheld is you talk to your doctor about it. If your doctor doesn't know about it, you say, well, who would know about it? Is there an infectious disease doc at your hospital? Is there somebody who's taking care of these patients that are immune compromised? They might know about it. And then, you go down the screening form, and if the person qualifies, typically what we do is we schedule them for a COVID test. Because we're giving the infusion in the infusion center with COVID and sitting next to all the other patients at the infusion. So we have to make sure they don't have COVID, even asymptomatic COVID. And then when they have a negative test, then we give them the infusion. So it's like 2 or 3 little steps. It's not an emergency, but once it goes in, you're protected for, we think, at least 6 months. It might even be as long as 9 months. So it's pretty cool.
All right, Chair Baisa, go check it out. Go ahead. Charlie, you had a question.
Yeah, so I guess everything that we've discussed thus far, there's this timetable on how long it lasts. So I guess the real simple answer will be, as long as we take care of ourselves, right, and try not put us in that dangerous situation. So I think with everything that's happened so far, especially those who just felt being cooped up for so long, um, the inhibitions have just gone out the window. It's like, I don't want to do that anymore, right? But I
It's the
think we
roaring
still have to
20s.
we still have to we still have to practice it. I mean, until such time they come up with something that says, hey, it'll be good for 5-6 years at a time, you know,
Right.
because
I
it seems like the duration, it doesn't seem long as one would anticipate it to last, right?
Yeah, so the vaccine protection, where we see this waning effect against breakthrough infection. So what we're seeing is with Omicron in general, breakthrough infection, because it's immunologically different than the strain that was used to make the vaccine. So one partial solution is going to be update vaccines so that it targets the circulating variant. Some of the vaccines that are coming through the pipeline, hopefully in time for fall, winter, are going to have the current variant on it. The problem with that strategy is that the virus mutates pretty quick. And oftentimes, even if you update the vaccine, by the time you get it out to everybody, there's already a new variant circulating. So that's not going to be a definitive fix. There's other vaccines that they're looking at that will, protect against multiple variants. And the real holy grail would be to get a vaccine that protects against multiple variants and provides a high level of antibody protection that lasts at least, say, 9 months or 12 months. And I'm hopeful that we'll do that. But I don't know for sure that we'll be able to do that. Coronaviruses in general seem to be resistant to that strategy. And if you look at, coronaviruses that have been used in animals, if you look at veterinary coronavirus vaccines, they've often had the same problem where, they're protective of a certain population for a certain amount of time, but they don't last forever. And it's because the virus has evolved to be very good at jumping from nose to nose to nose. It doesn't necessarily invade the lungs on every person. And as a result, you don't necessarily get the full immune response, right? So one thing would be intranasal vaccines or another strategy that may boost our ability to protect. But I suspect we're going to have this problem for quite some time, where we're really good at keeping people out of the hospital now, but we're not really good at preventing mild infections. And I think that's just the world we live in. And this is different. I've had to adjust my thinking. In 2020, I was like, let's eradicate COVID in Hawaii. That was my mindset, because we had a virus at that time that was not much more contagious than flu. So things like making people wear masks and doing testing at the airport and doing asymptomatic screening of populations that were large, congregate populations indoors. Those types of strategies had a good chance of success in terms of eliminating transmission within the islands. And unfortunately, that stuff doesn't seem to be working very well against the current circulating variants. And people should read a little bit about what just happened in Hong Kong for a good example of that. Hong Kong had possibly the best public health system in the world. I mean, they were excellent. They were one of the places that, for me, was a A-plus public health system that was a model in 2020 and early 2021, where they did, contact tracing, isolation, quarantine. They had border control that was really excellent. They did all the things that I wanted Hawaii to do at that time, and they continue to do those things. They're still doing them in 2022. You know what they didn't do very well, though, guys? They didn't vaccinate their elderly population very well, and there was resistance in their elderly population to being vaccinated for various reasons that I don't even fully understand. But one of the reasons is that some of the vaccines that were on offer were coming from mainland China, and didn't have the best reputation, and people were skeptical of that. But I think their over 65 vaccination rate was only about 50%, and their over 80 vaccination rate was something like 20%. So, in just a few weeks, they managed to sabotage all the work that they had done in 2 years with tremendous public health. And they had a BA2 wave that just ripped right through. And the nursing homes and the elder care homes, and it killed thousands of people. They had the highest mortality rate in the world for a few weeks there, and thousands of deaths. So I don't think we can rely purely on these public health strategies. They can still be part of what we're doing, and I think they're still relevant. I think it's crazy that we're not masking like in airports. Like, that's nuts to me. I think that's just wildly irresponsible. But I don't think I would rely on any of those public health interventions at this point, because the thing is just too contagious. It's way, way, way more contagious than it was a year and a half ago. We're being forced to adjust our strategy to that reality. And for me, what's happened in my mind is it's a layered defense now. It's vaccination, and it's pre-exposure prophylaxis, and then it's early antiviral therapy. And I want more and better of those different lines of defenses. And then the non-pharmaceutical interventions are things that I still do when I'm in any kind of big crowded public area. I don't know when I'm going to be able to stop doing those things. I would love to be able to stop doing them, but I don't really want to get COVID, buying carrots at the grocery store. That's just not my idea of a good weekend, So I wear a mask in the grocery store. I'm kind of shocked that people don't, honestly, It seems like a really dumb reason to get COVID. It's not hard to wear a mask in a grocery store. Your freedom is not being taken from you, So it's just something I do. I have to travel. I'm going to be in the airport. I'm going to be wearing an N95 in the airport. I don't want to go in the men's room at Honolulu International Airport. I don't need to see your smile in the men's room at the airport. I'm going to wear a mask. I don't understand why people are insisting on that. That just seems childish to me. In these kind of big public settings, it's better to protect yourself. And then whoever's unlucky enough to run into you after you've been in that setting. It's just courtesy.
Well, just recently they released a report just for Lihue Airport as an example that we're twice the amount pre-COVID of travelers coming in at this time. And I guess what's amazing to me, when I leave my office, if there's nobody around, I won't have a mask on. The moment I see a crowd, it's like, getting wigged out, like, oh boy, okay, take it out. But if you look at the lines and just the amount of interaction, I'm really proud of the airport workers. I'm watching them, and many of them use their mask because they've just got so much of them. And the only ones that can avoid the crowds are the ones that are working downstairs on a ramp because people can't get there, right? But everything on the main level in any concourse, I mean, whether it's Honolulu, Hilo is it's an okay. It's not really overly busy. But then you got Kona, you got Maui. I mean, look at Maui Airport. Running 8 lines and still you're taking 2 hours standing in line to get through TSA. But you look at the amount of people wall to wall not wearing masks. I mean, it's just utterly crazy.
Yeah.
Crazy.
And the prevalence high because we're having thousands of cases a day. So several of those people are active infections, and with the transmissibility of this virus, those are super spreader events that are happening all over the place. Now, that doesn't mean that all those people are going to go to the hospital. Obviously, the vast majority of people who get infected in a situation like that now will be fine, especially if they're vaccinated, especially if they can access early antiviral therapy. But I don't think you're nervous worry for wearing a mask in a situation like that. I think you're what you are is you're courteous. You're thinking about yourself, but you're also thinking about your family members, and you're thinking about somebody who you may encounter in that big, large, crowded space who maybe doesn't have a good immune system, but has to walk through there anyway, or maybe doesn't have access to the kind of therapies that I've been talking about for the last hour or so. And it's a sign of your consideration and your courtesy to other people to mask up in that situation. That's how I see it. I don't see it as like a nervous thing. And I understand people are trying to reframe it that way because they want us to not be thinking about COVID anymore. But the reality is we're going to be dealing with COVID indefinitely, and we're going to have more waves. And we may at some point have a wave that escapes some of the therapies that I've been talking about, and that is a more deadly wave. It's not guaranteed to become progressively less deadly. It's great that it has. But at some point in the future, we may be dealing with something bad. And when we have uncontrolled transmission, we're likely to have mutation and evolution of the virus. So I think in these big crowded indoor spaces, it absolutely still makes sense to be thinking about transmission. It also certainly makes sense to be thinking about transmission when the risk in the community is going up, like it has been in the last few weeks.
I know you mentioned airports, but I'm assuming you mean the same for airplanes, right?
Yeah.
Planes are there. Very few people are masking up in planes right now.
Right. And what the airlines say is, we've got really great air handling systems, and you don't have to worry about it. And I don't know. If you believe that, I got some land I want to sell you in Florida. I'm sure it's. Yeah, I think probably when you're mid-flight with a HEPA filter and the air filtration in the airplane, that's probably a little bit lower risk than when you're all bundled up in the airport security line. But you're still putting 200 people into an enclosed aluminum tube. It is what it is, right? And I wear my mask in situations like that. I peanuts. Don't eat the peanuts. That's my advice. There was one other point. There was one other point that came up, and I'm kind of an NBA fan, and everybody knows about the anti-vaccine stance of some of the NBA players. Kyrie Irving was very famous for not wanting to get vaccinated. Got a lot of criticism. There was a player on the Sixers, which is my team, named Matisse Thybulle, and he's from Australia. And it turns out he was not vaccinated, and he was a little smarter. He gave a much more elegant reason. And what he said was, I wanted to get vaccinated because it was like the pro-social thing to do. But when I realized that vaccines don't prevent transmission, I decided not to complete the series, because the reason I was doing it was to protect people around me, and I realized I couldn't protect people around me by being vaccinated. So therefore I didn't follow through with it. And it being Philadelphia, people kind of shook their shoulders, and then they booed him anyway because he couldn't play in a couple of games in Toronto. So it didn't work for him. But I remember thinking to myself, I was there because I wish I could set Matisse straight that we do think that vaccines affect transmission. So it is also part of being courteous. And numerous studies showing that if you're vaccinated and you're up to date, you're less likely to transmit to other people. You may get a breakthrough infection, but you're less likely to transmit to other people. And that's true for Omicron. It's even true for Omicron. There was a big study that was just published in Nature, and it was done by a Swiss group. And they actually looked at breakthrough infections, and they tried culture virus out of people's noses. And what they found was people who were up to date with their vaccination, which for Omicron meant a third shot, they had less infectious virus, even when they had a breakthrough infection. There was less, they had less of an ability to culture it out of their nose. It had the same result for Delta. We had the same result for the previous wave. So it's not that you can just stop wearing a mask when you're vaccinated, but you're less likely to. So part of being courteous is wearing a mask, and part of being courteous is turning off the Joe Rogan and getting your vaccine and taking care of the people around you, because we do think it helps.
No, I apologize. I wanted to maybe set the record straight here. Well, when I said that, when I come out of my office, what I meant to say is, when I see the crowds, is like, are all these people still traveling? That's why I throw my mask on, right? Because it's just like a big tidal wave. You you know,
Yeah,
if I need to go and do an inspection, I'll go through a special door, right? But to get to it, that means I go against the flow of traffic, and you've got
Yeah,
these people just walking into you. It's like, and if you give way and you don't make your way to this door that you have to get to, you're gonna spend an easy 30 minutes just waiting. So,
yeah,
you know, and it's unpredictable because, like any airports, and I think the best thing for people to understand is, if you think that an airplane is going to arrive and you've caught it several times and you always come at the specific gate and it's always going to be that gate, well, you got another thing coming, especially when there's something wrong with the jetway. They'll put you down, like at Honolulu Airport, as an example, before you go through that middle TSA line, right? Now you go to that new section, that pretty section. And if you fly to Kauai, you're going all the way up towards the mountain. You go in through that TSA checkpoint and you walk all the way down to the ocean, which is the opposite end. So, I just want to let people know that you're going to be walking across the traffic of a lot
yeah,
of people at this point. It's happening. It's happening.
yeah, yeah,
hey Doc, I know it's 8:04. And I hope you can indulge us for a couple of minutes. I just wanted to talk about the mask. Last year, here on Kauai, and I'm sure other islands suffered the same thing. Our people were denied access to tests because of the shortage of tests. Our people had to drive in from the west side or the north shore, drive into the Hui to the convention hall, get in by 6:30 or 7 so they could be there when the doors open, so they get a number and a time that they would have to come back to get their test because there was a shortage of tests. We just found out that the state is going to be destroying 750,000 tests uh, at a cost of $22 million, and they're going to pay somebody $63,000 to destroy them. I, I'm livid. I'm going to be very nice here. I mean, I say it's gross negligence because those tests should have been made available, especially to y'all on a big island, especially here on Kauai, because we were short. I just got to ask, what are your thoughts, man? I mean, that just to me is,
yeah.
I don't know the word.
I think it's a scandal. I really do. It should be a scandal. Um, we were told that we couldn't do post-arrival testing because there weren't enough tests, right? This was something that I heard repeatedly in 2020. Then we were told we couldn't get tests because the tests were intended for nursing home use and for schools. And then we were told, well, the nursing homes and the schools have arranged for alternative tests. Okay, so then use those tests for post-arrival screening. Well, we can't do that. We're not authorized to do that. So, it's an emergency proclamation. The key word there is emergency. And in an emergency, when you have a resource that can be used usefully and it hasn't been assigned properly, you go out in public and you say, I have this resource, I want to use it, I need to reassign it. This is what I need. If anybody in the Department of Health had done that, or if anybody in the state government had done that, no one would have argued with them. There would have been no argument about that. It would have just happened. We had post-arrival testing here on the Big Island. Post-arrival testing is not for tourists. Post-arrival testing is for locals. We test people after they arrive to protect locals. And this was particularly important in early 2021 and mid-2021 when we were struggling to get people vaccinated early on and we were struggling to keep out viral variants. And we could have used those tests. There's just no doubt about it. Kauai could have used those tests. Even if only the Big Island and Kauai had used them, you could have improved the safety of those two islands for several months, even if you had not gotten any more tests. So instead they sat on it like guarding his hoard of gold, and nobody's allowed to touch it. And now it's going to be destroyed. And I think it's atrocious. I just think it's horrible. And they deserve whatever criticism they get. There were multiple people who tried to talk to them about it, myself included, and got nowhere.
Yeah, I again, it goes, accountability. It's not even talked about anymore. I honestly believe that they were trying to control the numbers. They were trying to control the numbers of cases so they could move forward with their opening of tourism, and they succeeded. They got what they wanted. and they wasted $22 million worth of tests. I'm just pissed off because there are a lot of people that could not get tested, that may have had symptoms, that may have had or felt that they were a close contact and were turned away. And now I know that they had 750,000, 750,000 test kits sitting in some freaking warehouse somewhere on Oahu. $22 million. It's driving me nuts. It just pisses me off. And if this legislature doesn't call for an investigation, people, remember what I told you guys earlier. Remember in August, not November. Primary election is in August. You guys go out and vote these people out that cannot even hold these type of guys accountable. I just pissed off, and
we were talking a little bit about this before the show, but there's things that the health department does very well, I think. If you're talking about established diseases with protocolized treatment, their TB control branch, which was under Liz McNeil until she recently retired, I think was excellent. It was an excellent branch. It still is. Leprosy. I've got one or two patients that have leprosy. The public health nurse accompanies them to the office, make sure their pill box is filled out properly, make sure they understand the medicine, contacts me immediately if they're having side effects. I mean, these are things that they do tremendously well. Restaurant inspection. It's nice to eat a cheeseburger and not get typhoid. We can thank the health department for that. So there are things that they've been doing for decades quietly, very, very, very competently, that I would want to preserve. Emergency management is not one of those things. This has been a complete disaster from the beginning, frankly. And the common theme is inability to be flexible, an inability to adjust, an inability to make good use of resources, an inability to work with outsiders creatively. And I think this needs to be overhauled. It just obviously needs to be overhauled. And whoever wins the next election, that should be priority number one. It should be, whatever our emergency response management system needs to be looked at very carefully. And things need to change because pandemic response is a verb. It's not a noun. It's a set of actions. It's a set of duties. It's a set of responsibilities. And this is where we've failed, I think.
And we still got 7 months left in this term. I think people gotta, our legislature gotta step it up. And they were in session. They're done now, so that's the excuse, I guess. But somebody needs to track $22 million. Jesus Christ. Anyway.
Yeah, and 60,000 to destroy it. I'll just throw it out, guys. I'll destroy it for a cool 50,000. Just give it to me, and I'll waste $22 million for the mere sum of $50,000. How does that sound? It's maddening. It's totally maddening.
Yeah, it's beyond maddening. Hey, folks, if you guys wondering who this guy is, Dr. Jonathan Dworkin, let me just put this up real quick. Plague Doctors. He wrote Plague Doctors. If you haven't gotten this book, folks, Amazon.com, go check out Plague Doctors. It's an awesome book. It's the roadmap that was never followed, and it should still be used. The information in there is quite appropriate today as it was a year and a half ago. Plague Doctors, Amazon.com.
And it's not all gloom and doom, guys. It's actually, I tried to write it with an optimistic bent because I am fundamentally optimistic. I think there were a lot of things at Hawaii, right? And, it tells that story too. It tells the story of our success as well as our failure. And I really try to celebrate, the frontline doctors and nurses in the book. So it's my view from the trench. And there's some dark comedy in it as well, but yeah, it's not all bad. It's not all just about what did wrong. It's not that bleak.
It's a fantastic book, folks. Plague Doctors, Amazon.com. Doc, any closing comments before we shut down and let you go?
No, I don't have any brilliant insights. It's nice to be back and see you guys. It's been too long, and I appreciate the community that's formed around you and all the work that you've done to protect Hawaii. I've got my Protect Hawaii T-shirt on, which I wear around when I'm rounding, and it's fun to be part of this tribe.
Awesome, thank you, Doc. Charles.
Well, thank you very much, Doc. for being on tonight. Uh, to the village out there, interesting topic. I know we covered some things that we've always talked about before, but again, what's happening now? It's upon us, and it's not going to get better. But we got to keep a positive outlook. Uh, no use, no use blowing a fuse at this time. Uh, things happen. Sometimes there's no rhyme or reason, but one thing that will not happen to Uncle Charlie is I will not fall victim to this virus, only because I don't want to be a hypocrite, and I just want everybody to be hopefully the same, and that is protect yourself at all times. That's all I can leave you with tonight. Back to you, Mel.
Thank you, guys. Again, happy birthday to George White, one of our loyal villagers. George, and a contributor to so much data and information on Facebook and Instagram and all of the social media channels. Happy birthday, George. Hope you have a good evening, man. Wanted to also remind everybody on Saturday, the Troy Barboza Law Enforcement Torch Run benefit for Special Olympics. Please come join me at Vidina Stadium on Kauai, 7 a.m. We're going to walk. I ain't running. We're going to walk. Nice casual walk. Support Special Olympics. Great cause. $30. Get you a shirt, and we can have some fun down there. And I forget, I mentioned earlier, 10 o'clock on Saturday morning. This Saturday, 10 a.m., Kai Kahele will be making doing a press conference. I think you all know what's happening. It will be worth your time to pay attention. I will be streaming that press conference live on our social media channels on YouTube and LinkedIn and Twitter, as well as Facebook. Please, please, please tune in. I think it's the news everybody's expecting and everybody's been waiting for. Saturday morning at 10 a.m. Remember, in August, not November. All right, guys. You guys all take care. God bless. We love you all. We'll see you guys on Friday night at 7 o'clock. Dr. Dworkin, thank you, thank you, thank you. Keep up the good work, and we will be in touch, my friend.